Good day, people. We're here to talk about my personal pet peeve within osteopathic manual therapy and other therapeutic modalities. My personal pet peeve is what I would consider an overemphasis on the sacrum. Okay? The sacrum, by all accounts, has, by generous accounts essentially, the generous belief as to how far, or the generous proof as to how far the sacrum will actually move between the innominate or between the ilium, ischium, and pubis is about 2 to 4 degrees. Okay? 2 to 4 degrees. It doesn't move much. It's highly ligamentous. There's a lot of muscles crossing it. It's in an area where it's not going to move much. There is research to suggest that pre and post treatment, right, when properly monitored, there is no change in the motion of the sacrum. Okay? So we have research as a starting point that suggests that even if we treat in our minds these joints in here, they don't change much. Okay? People will present with pain in the region. Okay? They will present with pain in the pelvic region. They will believe it's their tailbone, is what they'll tell you. They will believe it's their sacrum. And it may very well be true. That may be exactly where their pain is. However, one of the things that we should also consider as far as locating pain is that for the majority of our body, our multi-point discrimination isn't particularly accurate, right? So hands, lips, and feet, our multi-point discrimination, our two-point discrimination is fairly accurate. Everywhere else it gets a little bit less accurate. We're not particularly accurate at identifying on ourselves the pain that we feel or the location of the pain within these regions. If something's torn, if something's broken, we'll know exactly where it is because it will be very, very, very sensitive. It'll be very specific. But sometimes the pain is just in this general area. And we don't know, as an individual, when feeling the pain, if it's the tailbone, if it's a facet joint, if it's just muscles, if it's just soft tissues that are having uneven load on it. We don't know for sure. What we get, though, is this emphasis on the sacrum and treating it and treating it and treating it and treating it here, right on it, or pulling an innominate away from it, which won't move very far away from it. Again, generous estimates of motion of this between the sacrum and the innominate, 2 to 4 degrees of motion. Not a big deal. What we want to start to consider, and I'll show you what I'm talking about with a patient on the table, is considering all of the anatomy that runs along the entire vertebral column that lands here. The legs, the influence that the legs can have in pulling on the pelvis and creating pain here. Uneven loads, generally speaking. Looking at the majority of the motion in the sacral region as being between L5 and S1. Again, we'll talk about this. I'll demonstrate it on the table. But I just wanted to have this spine to point to show you this is the area we're talking about. People literally basically get myopic. They fetishize this when they probably shouldn't. We have proof, again, that I've spoken about earlier that suggests that treating this makes no change to it or to its motion. So maybe we should reconsider what we're doing, reconsider our search pattern, and I will demonstrate that on the table. I'll show you what I'm talking about. So we're here talking about the sacrum. Now when we talk about the sacrum, we want to invoke one of our patient positioning concepts, that we want the anatomy to be exposed, free to move in the plane required, and preferably visible. So it's exposed, free to move in the plane, no plane is required, and it is visible. Now what we have within the osteopathic manual therapy community is a lot of talk about the sacrum that isn't necessarily something that can be proven. We've talked about that in the introduction. What we'll talk about here, first, is identifying the sacrum. Secondly, is that it's probably not the thing that we should be looking at. As we said in the introduction, essentially generous estimates of how far it moves is 2 to 4 degrees, so very, very minimally. We also have research that suggests that pre-treatment and post-treatment, there's no change in the actual motion of the sacrum. So it's probably not what we should be looking at. As far as identifying the sacrum, what we do is we first use the concept of multisensory integration. So I look. Now, most of my patients are going to be wearing clothing. Well, actually, all of my patients are going to be wearing clothing. What I should say is most of my patients are going to be wearing clothing that has a seam right in the middle of their bottom, or bottoms, whatever that might be, whether it's pants, shorts, possibly a dress, possibly a skirt. I would suggest to patients most of the time to wear long pants, loose pants, so that we can move them around comfortably. However, they may choose to wear something different and you can't absolutely control that. but there will be a seam right in the middle. So I use my eyes, okay, so one sense. I use my eyes to identify this midline, okay. I also use my eyes to identify the fact that the lumbar column is essentially a lordotic curve. So the bend is to the front, so it's an extension, so it will dip down. And then the high point, so I understand that the sacrum essentially tilts forward, and that I'll see a high point. So not only do I see the seam, I see a high point, a point that's above the lumbar column. So I know that the lumbar column's relatively in this area. I know that there's something higher than it. Now I'll use my hands. So I've used my eyes, I'll use my hands now, so I see where it should be. I'll use my hands broadly to identify where it is. Okay, so I use a broad contact, so our concepts of palpation move from the known to the unknown, get as much as you can touch, things of that nature. So I just broadly contact here. Now what I'll notice is the glute tissues, I'll notice the bones, I'll notice the high points, the low points. So what I need to do with this patient is I need to move a little bit further down. Now I have the sacrum fully in my hand, or at least I have the midline of the sacrum identified. So from here, we've talked about it before, I can identify PSIS. By moving laterally, I can identify many things. What we're going to do is look at one of the tests with the sacrum that a lot of people like. However, I don't think it gives you the information that you think it gives you. So we're going to just have them take a deep breath, and we're going to use our eyes to take a deep breath and let it out. Okay. So a lot of people will tell you that that test in particular will tell you many things about the sacrum. So respiratory assistance. Some people like to do it when the patient is in supine. What ends up happening is as the patient breathes, the abdomen and the false pelvis inflate. Right? So as we take a breath in, the abdomen and the false pelvis inflate, so the abdomen changes the pressure gradients. Everything moves off the table. Now, if everything's moving in relation to the table, ideally we should get vertebral movement, we should get movement at L5S1, whatever it may be. The challenge being that what we're really seeing for sure is inflation of the abdomen. We are likely seeing related motion of the vertebral column and some possible motion of the sacrum, but again, it's 2 to 4 degrees. We're not sensitive enough to pick that up in many cases. So this test will tell us if as the abdomen inflates, things move or things are uneven. So there's information available here. What we see, and it may not be visible on the video, but what we see is this side is towards the table, this side is away from the table. As the patient breathes, it does not change, it stays the same. So we see an asymmetry. Some of us may go ahead and say that asymmetry is in the sacrum. Some of us may use our eyes and see that the asymmetry is actually up here. It's much larger, right? Do we have proof that that's absolutely the case? We have proof that in this position it's the case. We don't have proof at the moment without testing in different positions that it's consistent. Some people like to do essentially sacral overpressure. Now here's the problem with this. As we push, we don't know how much is movement of the sacrum between the innominants. Again, generous estimates at 2 to 4 degrees of motion. We don't know what is the sacrum moving between the ilium, sacrum moving between the innominants, or the amount that the abdomen of the patient is being squished into the table, and that's what we're picking up. So these tests are not likely as useful as we want them to be. Now the most mobile portions of the sacrum are at L5S1, or between L5 and S1. So what we really want to know is what's happening at L5S1, and we can identify that by coming from the sacrum, coming up, moving through, identifying the first essential bump above it, which is often at L5 covered by fat or muscle. So it's not the easiest thing to find, and we don't know if it's L4, L5, or L6 as we've discussed before, but we want to assess movement here. Now if we're only assessing movement here, we're ignoring the rest of the column. We're ignoring the erector mass, we're ignoring the latissimus, we're ignoring the obliques, we're ignoring many things that may contribute to motion problems that we visually and through palpation identify here. We will see people performing tests like this, seeing what's occurring. So they'll span, so they'll have fingers on the sacrum, they'll have fingers crossing onto the ilium or the innominate, however you want to term it, and they'll do this, and they'll say that they feel motion. What more likely than not they're feeling is movement of the soft tissues in the region. They're not necessarily feeling motion of the bone, because if you could feel that motion, that would suggest that the patient has a very unstable sacroiliac joint for that much movement to happen, because the majority of the motion, or the generous estimates, are 2 to 4 degrees. So again, we come back to that 2 to 4 degrees. So all these tests that we commonly do for the sacrum probably don't tell us much about the sacrum or the sacrum in relation to the ilium. What they probably tell us about is the hip. So as I just did, this tells us quite a bit about the hip, right? The soft tissue tensions that are on the hip that by inference we will feel in this region. Respiration will tell us about what's happening through the column, what's happening through the abdomen, right? General gross asymmetries. All of this to say that when we think about this sacrum, and when we put our focus here, we are likely ignoring the rest of the column. We're likely ignoring all of the things that will actually create motion in this. So we know that the thoracolumbar fascia is here, that the multifidi invest on the sacrum, that the erector mass invests on the sacrum. We have a lot of muscular pulls that end up here. We'll name it off of this bone and its relationship to the ilium, although it doesn't move much. So what we're doing is we're ignoring the reality of the rest of the body. So what we want to do is go back to our assessment concepts. Macro identifies micro, have a distinct algorithm, right? We want to move through those things to identify whether or not there's something up here, or whether there's something in here or here that's pulling on this. We put far too much emphasis on the sacrum itself. When it moves very little, what motion it does have will be heavily influenced by larger structures, so we want to consider those larger structures. So hopefully what this video has done is shown you some of the tests that people will use, and said possibly why they may not be as useful as you want. We don't know if it's the abdomen, we don't know if it's the erector mass, we don't know if it's the thoracolumbar fascia, we don't know if it's the hip. We have ways to test those things, but our tests probably give us false positives, especially the respiratory tests. Even when people short lever test L5 on S1, they haven't differentiated between what may be going on in the hip, what may be going on in the abdominal obliques, what may be going on in the erectors. We haven't differentiated. We want to be able to do that. That's why we utilize those concepts in assessment of macro identifies micro, and macro identifies micro and go through a consistent algorithm, or have a consistent algorithm. So hopefully, again, what we've seen is that the tests that we're using for the sacrum may not be as useful as we think they are.